Thank you for coming to the Leukemia Research Foundation Town Hall meeting. My name is Carrie Callis, and I am the Director of Programs at the Foundation. Our annual Town Hall meeting is typically an in-person program, but this year, for obvious reasons, we made it virtual. While we have always made program recordings available, this virtual format has allowed participants from all over the U.S. to be a part of the program. We have over 300 people registered for the program today. We thank our generous supporters shown on your screen for helping to make this program possible. As a brief background about the Leukemia Research Foundation, the Foundation's mission is to conquer all blood cancers by funding research into their causes and cures and enriching the quality of life of those touched by these diseases. Raising over $80 million in support of its mission since it began in 1946, the Foundation has funded research grants to over 500 new investigators on 5 continents and supports patients and families living with a blood cancer diagnosis through educational and support programs. To learn more, please visit our website, allbloodcancers.org. Before we begin, I wanted to give a quick plug for our upcoming virtual program, Managing Treatment-Related Side Effects of Blood Cancers, on February 22nd, which will be a virtual program presented by Dr. Deborah Katz from Rush. You can register on our website, who is our moderator and a panelist today. He is the chair of the Foundation's Medical Advisory Board, and he's a regular patient education program contributor. So I will first turn it over to Dr. Stiff to introduce himself, and then we will ask the rest of the panelists to do the same, and then we will get right started on your questions.
Hi, good afternoon, everybody, and welcome. This is new to all of us, and again, I'd like to thank everybody from all over the country. We got a big snowstorm here, so hopefully the weather isn't as bad there as here, or that you're inside nice and warm. Again, I'm a professor of medicine and pathology at Loyola University Medical Center, directed the transplant program for many years, and as Carrie mentioned, I'm chair of the Medical Advisory Board for Leukemia Research Foundation, and we are charged with funding new investigators with their research projects on a once-a-year basis from funds that are donated by folks like you and others to the Leukemia Research Foundation. We've started the careers of many young aspiring researchers, and this is a pay-it-forward type of a process. So I'm happy to be here. We'll be moderating, and again, if you have questions that you didn't ask previously, please enter them into the chat box, and we will take time to answer them about 3/4 of the way through. Next, let's go to Dr. Vino Gopal to introduce himself.
Thank you, Dr. Stephen Carey. My name is Vino Gopal. In fact, that's my short part of the name. I am from Chicago. I work at Rush University Medical Center. I'm a professor of medicine, and I specialize in blood cancers.
Next, Dr. J.S. Mehta.
Hi there. Thanks, Pat and Carrie and LRF for organizing this. I am at Northwestern Memorial Hospital and Northwestern University. I direct the stem cell transplant program, and my interest is all hematologic malignancies, especially plasma cell disorders, that is myeloma, amyloidosis, and Waldenstrom's macroglobulinemia.
And last but not least, Dr. Samuel Katz.
Hi, everyone. Thank you for joining with us, and thanks for giving me the opportunity to be here as well. I'm an associate professor at Yale University. I've been here for a little over 8 years now. I trained both as a medical doctor as well as a PhD. So I'm an MD PhD, and I spend part of my time in the laboratory researching new ways to fight against blood cancers, some with the help of the Leukemia Research Foundation, which supported my lab a little while ago. And then I also spend part of my time diagnosing blood cancers as a hematopathologist, looking at slides and determining what type of cancer people have.
All right, so let's get started. I'm going to ask two general questions of each of the panelists. And the first one comes from a patient that I saw recently who was referred to me by a community oncologist. He had had two bone marrows for a blood problem with low blood counts. Both bone marrows were unable to make a diagnosis. And he came to me, I think both he and his doctor were a little frustrated that they didn't have a diagnosis, and yet he was starting to require blood transfusions. What we did is a third bone marrow, and I did some molecular typing, genetic typing. It did show that he had a genetic alteration in his bone marrow stem cell population, which was likely the sole cause of his blood count problems. So the first question I'd like to ask for each of our panelists, maybe starting with Dr. Katz, is can you talk a little bit about molecular typing of blood cancers? Feel free to focus on one disease or the other. And then for each of you who specialize in specific diseases, most of the time talk about molecular typing that you would do for patients with myelomas, lymphomas, and leukemias. Dr. Katz.
Yeah, absolutely. So that's not that uncommon of a scenario that you point out. And I think it's most commonly seen in cases of myelodysplasia. So that's where the myeloid lineage, which are the ones that make the neutrophils and the eosinophils that help fight off infections, have something a little bit odd with them. And as a pathologist, our first step is to look at it under the microscope, and we could see in many cases where they look a little bit funny. There will be certain morphological findings. That said, not every case can we see the morphological findings. And so we often do like to get what's called a myeloid gene panel to help us out. And sometimes we can find specific mutations that we know are associated with these myelodysplastic syndromes at certain frequencies, and that can help us establish the diagnosis.
Okay, Dr. Vino Gopal, when would you do these molecular tests for patients that you see predominantly with lymphoid malignancies?
In some patients, we do it first time itself, first time they are diagnosed. For example, if a patient has an aggressive lymphoma, diffuse large B-cell lymphoma, it's important to know molecular factors right up front. If they have a MYC mutation or BCL2, BCL6 mutation, that can change the initial treatment itself. So that's one. And second, when they relapse, when they come back with disease, we can test it not only for diagnosis, but also for identifying the appropriate medication. For example, the most recently approved, FDA-approved drug for that particular purpose based on a molecular marker is something called EZH2, which is a molecular mutation. And there is a drug, an oral drug now approved for follicular lymphoma based on that. So in some patients, we do it up front. In many patients, we do it when the disease comes back to look at the treatment options based on these markers.
Dr. Mehta, for plasma cell disorders and amyloid.
Our standard testing would be to look at cytogenetics either by conventional, well, not either, by conventional G banding and also by FISH. And if we get adequate information, positive results that give us an idea of whether the disease is low risk, medium risk, or high risk, we don't necessarily routinely do molecular level testing like next generation sequencing, but If those studies do not yield enough information, then we definitely proceed to molecular testing. And I have a feeling that going forward, as the influence of molecular testing on the outcome of plasma cell diseases becomes more and more clear, I expect that we will start doing it routinely on all patients.
And I can answer for acute leukemias and chronic leukemias, of course, for the CMLs, the Philadelphia chromosome, and the BCR-ABL gene construct certainly is something that we measure and use to monitor disease status. But for adults and even children with acute leukemia, it's important test that we do in all patients now, starting with the time of diagnosis, largely because, as several have mentioned, we now have treatments that can be used in patients with these certain subsets. So, for example, FLT3 positive leukemia, we have FLT3 inhibitors, actually several generations of them. And even for children and adolescents with acute lymphoid leukemia, there's a new condition called, recently described, Philadelphia chromosome-like ALL, only diagnosable by doing gene profiling, and certainly is important to know because it's associated with an inferior prognosis. So I think that as time goes by over the next few years, these will become more and more commonplace. Again, we very frequently, when we see a new patient who's been under the care of another physician for a while and they can't make a diagnosis, this is usually one of the things that we pull out of our toolbox to help make the diagnosis, as Dr. Katz indicated. The second question, again, is a group question, and I think, again, broad strokes, one of the questions that came in was, what's the life expectancy of newly diagnosed patients? In other words, how has life expectancy improved over time for the blood cancers? And let's go in the same order, and I'll let people pick diseases, compare and contrast, and what they see has happened over the last 5 to 10 years for diseases. So Dr. Katz?
Sure. So, I mean, there's no question that the survivals have been improving dramatically in some cases over the last 5-10 years. In fact, you know, as a pathologist, I recall, just to pick up on something that Dr. Stiff mentioned recently with CML and BCR-ABL, I remember when I was training that I often would see bone marrows where they were completely full of cells that are indicative of the disease. Now, when I get a marrow on people who have CML, it could look almost normal. And it's very difficult to tell without having that molecular test now that you're able to see something at much, much more minute levels. And so in general, I think it really has been quite dramatic, and it makes it for a great career to be in, to see it improve this way.
Dr. Vino?
Yes, as Dr. Katz said, I mean, certainly there is evidence that the survival has improved, not only survival, but quality of life of patients with various malignancies have improved over the years. And one more point I want to mention is now, unlike in the past, when we depended only on chemotherapy, we are able to achieve the same or even better survivals with better quality of life without using chemotherapy. The classic example is chronic lymphatic leukemia, CLL, where FDA approved regimens in 2019 which are not chemotherapy, and you are able to achieve the same kind or even better survivals and better, quality of life.
So what is the survival of a patient with CLL diagnosed in 2021?
Well, it depends on various factors. It depends on the stage, depends on prognostic factors, because we have a variety of new prognostic factors, including molecular factors, and therefore the prognosis or the survival of an individual patient with CLL will depend on many of those factors.
So again, important to most accurately diagnose not only the type of disease, but also any genetic factors which might impact prognosis. So if you knew all these factors, are you able to, patient comes to you for the first time, to give them a ballpark of what their prognosis is going to be, or is it still too variable to really give that information?
I think if we have all the factors you just mentioned, including the molecular information up front, we should be able to give a very good idea of the prognosis of survival, except some of those can be refined after the first few cycles of treatment to see how the patient is doing, and then we may be able to give an even better or more accurate information about the prognosis.
Okay. Dr. Mehta, please speak to life expectancy of patient with multiple myeloma or other plasma cell disorders.
So in myeloma and the related diseases, just like in lymphoma, and as I'm sure you will refer to in leukemia, the outcome has changed dramatically. When I entered medical school, the median survival in myeloma used to be thought of as about 3 years, about a quarter century ago. And now we routinely think of the median survival of all patients as being more in the 7 to 8 year range. And if you have a patient with low-risk disease who is treated intensively enough, it is possible that a quarter of the patients may even be functionally cured, and the median survival could be in the 15+ year range. In some very high-risk cases, the survival still remains poor. But just like Dr. Vino Gopal said, when you have refined prognostic factor information available and you see how an individual is tolerating treatment and how they are responding to it, you can refine their prognosis much better. But an important practical thing I want to tell people on the call, which I tell all my patients, is that never be discouraged by a treatment option for an supposedly incurable disease that only gives you a year's worth of survival. Because think of that year as a bridge to the next good thing that becomes available. I think of treating myeloma as making a patchwork quilt. And anytime you refuse to use a patch saying it's not big enough, you are leaving a hole. It's important that you use everything that is available.
Okay, and I can maybe answer for acute leukemias. We are making steady and slow progress. And again, like Dr. Vino Gopal said, certain subgroups do better than others. And as we get into more and more targeted therapy for these, it is a disease that does seem to be associated with improvements in survival. So for example, the FLT3 positive patients, now with the FLT3 inhibitors, the prognosis does seem to be better. And again, for certain subgroups that we know are going to have an adverse prognosis, in the past we might not have considered an early allogeneic or donor transplant. Now we do, and those prognoses seem to be improving. And again, I think that the message that you're hearing from all of us is that the accuracy of the diagnosis is critical in choosing the best treatment plan. And the more tools you have to make an accurate diagnosis, the better your chances are of doing well long term. And then the second thing, again, is kind of a summarize is just because your disease has come back doesn't mean that novel therapies are going to fail. Sometimes some of the newer therapies are even more effective than some of the frontline therapies. And so consider your treatment failure with the possibility of coming up with something new, and clinical trials are pretty much everything that we do nowadays for many of the patients who have relapsed blood cancers, and consider those options for you. We do have some additional questions on FISH and genetic type testing, which we will get to in the second half of this. Let's go back again to the questions that came in. And one of them, again, we'll start with Dr. Katz. How do you diagnose and what are the prognostic factors for MDS, and if you can also comment on how does one get MDS?
Yeah, sure. So there are a lot of factors that can contribute to MDS. Some of them are environmental. Some of them can even be genetic. There is this entity called clonal hematopoiesis of indeterminate potential. Indeterminate because we don't quite know. And so you can wind up getting little clones that could grow over time. And some people, they go nowhere, and some people, they could lead into an MDS. In terms of how we go about diagnosing it, it's a multimodal evaluation. When we look at the cells, we use a technique called flow cytometry, where they go through a machine that tells us what it's expressing on its surface. We look at histology under the microscope so that we can tell the morphology of the cells. And we use various forms of genetic testing, including cytogenetics, where we're looking at whole chromosomes and what pieces might be missing. FISH, as was mentioned a little bit earlier, which stands for fluorescent in situ hybridization, which tells us a little bit more refined as to which pieces of the chromosomes might be missing. And then finally, genetic sequencing, where we look at the actual letters that make up our DNA, A, C, G, and T, and to see if any of them are mutated. And so it's kind of a confluence of all of these different parts that help us get towards that diagnosis.
Okay, next question for Dr. Vinu. Do chemotherapy treatments cure marginal zone B-cell lymphoma? And maybe just a word or two about what marginal zone B-cell lymphoma is.
Marginal zone lymphoma is a low-grade B-cell non-Hodgkin lymphoma. And as with most low-grade lymphomas, they may not require treatment for quite some time, but they are not diseases that we can say are curable. So in other words, it has a tendency to come back, although with the new treatment options, we do see very long remissions, but still it can come back. That's the reason why we don't call it curable. We don't call it a curable disease. And treatment options include a variety of things. Once the patient needs treatment, whether monoclonal antibody, chemotherapy, and also some of the new targeted treatments which are approved for this disease.
Next question is on smoldering myeloma. Dr. Mehta, the question specifically was, how can you send smoldering myeloma into remission? Or maybe we should rephrase it as, should you send smoldering, or when should you send smoldering myeloma into remission? Do you need to treat smoldering myeloma, I guess, is the bottom line.
So this is a very controversial point. The bottom line that I will start with is that I do not believe smoldering myeloma should be treated. The problem is that the definition of smoldering myeloma varies, and some people call myeloma that probably does require treatment as high-risk smoldering myeloma, and certainly such patients ought to be treated. But true smoldering myeloma, where there is no obvious indication for treatment, where you observe the patient for a few months and find that there is no material change, I would strongly recommend not treating because of the potential side effects and so on. One of the endpoints that has been used in some studies is that you delay the need to start treatment for myeloma by treating smoldering myeloma, which doesn't make logical sense. In other words, you are treating somebody to avoid treatment in the future. It's far better and far easier to avoid treatment and then treat only when the disease starts progressing. You don't necessarily have to wait for it to become full-blown myeloma. Once the disease is declaring itself as moving in a certain way, where it is going to, you can predict that it is going to become critical enough, go ahead and start treatment before that. But the majority of, in fact, all of true smoldering myeloma, I would not treat.
Next question is, what are the latest treatments for cesary syndrome? First, we'll ask Dr. Katz what the heck cesary syndrome is, and then Vinu, you'll have a little moment to try to figure out how to answer that one.
Sure. So Cesary syndrome is a proliferation of T cells. So this is a T cell lymphoma, and it also goes by another name, sort of, called mycosis fungoides, or cutaneous T cell lymphoma. So this is a T cell lymphoma that involves your skin, and you wind up getting patches, and it goes after your epidermis. Now, when it gets the extra name of Cesary syndrome is where it's left the skin and gotten into the bloodstream.
Okay, Vinu.
Yeah, most of the cases start with the mycosis fungoides, as Dr. Katz said, which is mostly treated by local application of medications to the skin, topical application. But once it is Cesary syndrome, it's more systemic and may need treatments which are systemic. That means you administer into the vein or take it by mouth so that it takes care of the disease in general. In terms of advances, most of the things in oncology now are targeted treatment. So one of the drug that was recently FDA approved for Cesary syndrome, it has a long name, mogamulizumab. So it is a antibody. It's a protein that is targeting another protein, which is something called CCR4, which is very effective. It's a very effective drug. So like that, there are one or two other targeted treatments also. One is called brentuximab. Brentuximab is an FDA-approved drug for Hodgkin lymphoma, large cell lymphoma, but it's also very effective in this disease. And the third group of drug I want to mention is something called checkpoint inhibitors like nivolumab, pembrolizumab is also very active in Cesary syndrome.
Okay, we have a few questions about CAR T cells. So what I want to do, again, this will be a group answer. Start with Dr. Katz to tell us what the heck CAR T cells are, and then specifically have Dr. Vino Gopal talk about CAR Ts for lymphoma, and Dr. Mehta to talk about CAR Ts for plasma cell disorders. Dr. Katz?
Yeah, happy to talk about this. So I'm actually pretty excited because CAR Ts is one of the areas that my lab has been working on. It stands for chimeric antigen receptor T cell. So we all know that T cells can fight off infections or by recognizing things that are foreign, and then the T cell can attack those cells. So when you can reprogram a T cell, it's called a CAR T cell. You put in this CAR into the T cell, genetically manipulate it, and you reprogram the T cell to now recognize a different antigen. So the one that's most well known is one that's called CD19, which is expressed on B cells. And so we can make T cells that now go after B cells, not just the cancer B cells, but all B cells. All B cells express CD19. And so this is one of the ways. Now, there are many other targets that people have been working on besides CD19. There are many different ways that people have been trying to reprogram these CAR T cells. We can go into details, but I think that's the general one.
Okay, Dr. Vino Gopal for lymphomas.
Yeah, lymphoma, diffuse large B-cell lymphoma, or one of the most common aggressive lymphoma. That's the disease where CAR-T was first approved in the setting of lymphoma. And FDA approved it for patients who already had two other forms of treatment, and still the disease is growing back. That's the situation where we use it. There are two types of CAR-Ts which are already in the market for this group of patients. CAR-T is also approved for another kind of lymphoma called Mantle Cell lymphoma, where treatment has been historically difficult, and it's a very effective treatment option for Mantle Cell lymphoma also. That having said, there are many other types of lymphomas where CAR T is being looked into, and there's a possibility we may see other types of lymphoma where this kind of treatment gets approved in the near future.
And Dr. Mehta for plasma cell disorders.
So there are no approved CAR T cell therapies for myeloma yet, but there is an expectation that something will become available within the next few months. At the moment, it is only being done on clinical trials at all the major medical centers within the city and elsewhere. It certainly seems to have extraordinary activity in patients who have failed multiple other lines of treatment. But unlike diffuse large B-cell lymphoma, where there is a potential for very long-term survival, the early data in myeloma suggests that the responses are not necessarily that durable. Most patients do tend to relapse, as they do with most other treatments. And I think future work ought to be directed at considering treating the disease earlier in the course of the disease, where one may be able to eliminate malignant cells much more effectively and therefore perhaps get more sustained remissions. But yet another arrow to add to our quiver, so to speak.
Okay, and then I can answer for acute leukemias. It's FDA, CAR T cells are FDA approved for pediatric and adolescent acute lymphoid leukemia, where again, like diffuse large B-cell lymphoma, it can be curative, even in patients that have failed an allogeneic or donor stem cell transplant. Adult trials have been completed and data is being analyzed as we speak. And I'm fully expecting that we're going to see CAR T cells, I'll predict that we're going to see CAR T cells approved for adults with acute lymphoid leukemia. For acute myeloid leukemia, studies are a bit behind these other indications. There are some exciting new data that are coming out, and we'll talk a little bit later about BITES, which also may be of value in this specific disease. And there's also CAR Ts for potentially for CD30 positive diseases. Dr. Vino Gopal mentioned cesary as being CD30 positive, but they're being looked at as well for Hodgkin's disease. Fortunately, most patients with Hodgkin's disease are now cured with upfront therapy or a second-line stem cell transplant, so I don't think we'll see big use for these down the line. But again, is being explored. And not only does Hodgkin's express CD30, but some of the T-cell lymphomas, as Dr. Vino Gopal mentioned, express CD30. So T-cell lymphomas are a basket of diseases. It's not very common. There's a few here, a few there. What's typical of them are they are very difficult to treat. And so we're looking forward potentially to this form of CAR T-cell being of value. Most CAR Ts are made from patients' own cells. You donate for yourself. But there are also clinical trials of using donor cells, which will be available in an off-the-shelf manner. Most CAR T-cell products take as long as a month to grow, and for patients with fast-growing diseases, this may not be optimal for them. Having a donor produce cells that can be genetically modified to make them safe to infuse in anybody, have these available literally in a freezer at a bank somewhere. When you need them, you'll be able to get them a lot quicker. Again, those clinical trials are underway, and we're hoping to see data on those cells in the next year or two. Let's move on. One of the frequent questions here has a lot to do with CLL, and I will combine several of these. One of them is there a cure for CLL? When should patients stop in the watch and wait? What is watch and wait? When do you treat? Is there a cure? And how long do patients need to take therapy for this disease? And finally, what about CAR T cells for CLL? I'll let Dr. Vino Gopal handle that one.
Okay, I'll try to make the answer very short. So the first question, is CLL curable? The only known cure I know for CLL is a bone marrow transplant from a donor, which we don't do nowadays very often in CLL because of the variety of new treatment options. But still, that is an option in some cases where, based on some of the molecular features, their disease has a tendency to come back frequently and be resistant to treatment. The second question was about watch and wait. Majority of patients with CLL at diagnosis are recommended for watch and wait because they do not need treatment. There are certain internationally accepted criteria for starting treatment. Simple things like if the patient has symptoms from the disease, or if the disease is causing organ dysfunction, like blood counts dropping and needing transfusion, things like that. So there are certain standard treatment options, indications for treatment. The third question is, how long is the treatment? Well, if and when treatment is needed, as I mentioned before, unlike in the past, we have several new treatment options, which are mostly non-chemotherapy treatments, which is what we do for most patients now. And there's a lot of clinical trials going on, trying to find out how long we should be treating these patients. Should we be treating them based on some of the molecular features indicating that the disease is clean at the molecular level, the so-called MRD, or minimal residual disease negative state? So those are not yet answered very well to be put into clinical practice, but in the future, we certainly will be able to use some of those information to decide how long is the most optimal treatment for a patient with CLL.
Okay, next, you did mention MRD. We're going to start, again, this is going to be a group answer. MRD. What is MRD? Dr. Katz, Dr. Vino Gopal, let's talk about MRD in diseases such as CLL and mantle cell lymphoma. And Dr. Mehta, MRD in multiple myeloma, and I'll try to answer MRD in acute leukemia.
All right, so I'll start by a general definition of minimal residual disease, which is what MRD stands for. And it's typically, in speaking in broad terms, when we don't detect it morphologically. There's so little disease, say in the leukemia space, where you're looking at elevated blasts, you no longer see elevated blasts or myeloblasts within the marrow. Instead, what you still can detect are those molecular changes that we had discussed earlier. And so minimal residual disease, therefore, is when it's morphologically not present, but molecularly still present.
Dr. Vino Gopal, CLL and mantle cell lymphoma.
So MRD negative state is always something exciting. That means we cannot find evidence of disease even at the molecular level. And there is evidence that if you achieve that kind of a state, the patients who are MRD negative may remain without the disease coming back for longer time compared to patients who are MRD positive. We have not been able to translate into clinical practice, except, for example, in chronic myeloid leukemia. We know that if they are MRD negative for a period of time, we can even stop the treatment. FDA even approved discontinuation of treatment if the patient is MRD negative for a defined period of time. So like that, we are hoping in CLL, we will have the data to say that, okay, you took the treatment for 18 months, you are MRD negative, you should be able to stop it. And even if it comes back, we should be able to put you back into remission by resuming treatment. We don't have that kind of information at this time. And as I mentioned before, hopefully we will have it soon. The same thing with mantle cell lymphoma. We have markers which we can look at either by flow cytometry or polymerase chain reaction. and detect the minimal residual disease in these patients?
Dr. Mehta.
So the minimal residual disease in myeloma, there is a commercially available assay called the clonoSEQ assay made by Adaptive Biotechnology, which allows one to detect the disease at a molecular level when all the other conventional tests show absence of disease. The test is not perfect. There are studies where conventional testing has shown some residual disease, and yet the clonoSEQ assay has been negative. But when the clonoSEQ assay is negative, myeloma patient is MRD negative, they have achieved the best possible response based upon currently available criteria. And we do know in myeloma, in general, not always in general, that the better and the deeper the response, the better is likely to be the long-term outcome. So I think it's fair to assume that somebody who is in a complete remission and is MRD negative may do better than somebody who is in complete remission and who is MRD positive. But a misuse of MRD in myeloma that has really crept up around in a big way without any data to support it at all is to actually make treatment decision to stop the treatment like maintenance therapy in myeloma because an individual is MRD negative. And whether that strategy is actually valid or not is not known. So I suspect that if you have a patient who is MRD negative who's getting maintenance therapy and a patient who is MRD positive and who's getting maintenance therapy, the one that's MRD negative is likely to do better, all else being equal. But we do not know that an MRD negative patient who is on maintenance therapy and an MRD negative patient who stops maintenance therapy are going to be equally well off in terms of long-term outcomes. So that's a leap of faith a lot of physicians have made, which I think is very dangerous.
Okay, so let me answer for the leukemias. Dr. Vino Gopal already talked about the chronic myeloid leukemia, and MRD is so important that we are able, in certain patients who have had MRD negative state for a prolonged period of time, to stop therapy. In these patients, there are Gleevec and dasatinibs and bosutinib's therapy, and approximately 1/3 of them will remain in long-term remission. We're thinking that this might be a cure. For acute lymphoid leukemia, MRD negative state, as early as 1 month into therapy is of prognostic import, and we're looking for new therapies for adult acute leukemia that will increase the number of patients who are MRD negative. There's a new trial that just opened up, a national trial that will explore the use of blinatumomab as consolidation therapy or as upfront therapy for patients with adult acute lymphoid leukemia. For AML, the data is a little bit less sure, but there's multiple studies that have shown that if you are in remission but are MRD positive, your results with a donor bone marrow transplant are not as good as if you were MRD negative. So some of the new strategies that we're about to test nationally will explore ways to improve the MRD negative percentage of patients right before transplant so that we can determine if that is associated with improvements in outcome. So as Dr. Mehta said, don't assume that just because you're MRD negative that it's because of the treatment. It may actually be because your disease is more likely to respond to therapy, and that therapy has gotten you to MRD negative state, and that because of that, you should continue therapy and not stop. So these are all detailed discussions that you really need to have with your hematologist or your blood cancer specialist and individual cases. But again, these are tests that you're going to be seeing more and more of. We're actually doing them now in patients getting CAR T therapy. And in fact, there's an upcoming trial that's going to explore patients that are MRD positive, even at 1 month after CAR Ts, that they might need additional therapy to tip them over to the edge of long-term remission. Next, and moving along, we got a bunch of questions. I'm hoping my colleagues will help in this regard. we got a bunch of questions about COVID-19. And while we can't talk a lot about the future, many of the questions had to do, I think, with prognosis and treatment, and more importantly, the vaccine. So I'll start off by saying approximately 1 week ago, there was data announced to suggest from the Center for International Bone Marrow Transplant Research that for patients who've had stem cell transplant, if you get COVID-19, your chances of a fatal complication could be as high as 30%, which again really emphasizes the fact that all of you out there that have had a donor bone marrow transplant or even an autologous transplant, to make sure social distancing, washing your hands, wearing masks, minimizing your chances of getting an infection. So that's a national analysis that was just reported, I think, last Monday. So I'm going to throw it open to anybody regarding COVID vaccine. A couple things we do know about it, that some patients are getting the COVID antibodies, the Regeneron antibodies. And one of the recommendations are that if you get those COVID antibodies, Regeneron antibodies, you should not get a COVID vaccine for 90 days. Those are antibodies that we use for patients with COVID symptoms that are not yet in the hospital. So I'll throw it open to any of you all to comment on who should get the COVID vaccine, and more importantly, when should a patient get COVID vaccine who's getting therapy for blood cancers? And is there a difference between treatments for myeloid malignancies, which may not have as much of a devastating effect on the cells that produce immune response, versus lymphomas or CLL or even multiple myeloma, in which antibodies production may be diminished? Who'd like to go first?
Shall I? So the one general statement to make is that neither the condition nor the ongoing treatment for a patient with a hematologic malignancy disqualifies them for the COVID-19 vaccine, because it is not likely to prove more dangerous to them. As Dr. Stiff said, it is possible that there are situations, and they might be more common than we like, where the vaccine might not be effective at eliciting the kind of immune response that we want. One of the things that we can do, which is obviously not appropriate for the general population, but for hematologic malignancy patients, is that at an appropriate time, maybe 4 weeks after the second dose or 6 weeks after the second dose, it could be worth checking the antibody to COVID virus in the blood to see if an immune response has been mounted. And that might give one a clue as to whether the vaccine has worked or not. Having said that, if a patient has had transplant or treatment and are not currently on active treatment, then I think it's reasonable to give the vaccine without worrying too much. A patient who is on monthly treatment, perhaps one could give treatment halfway between the treatments, sometimes even skip a treatment after the vaccine is given to allow the vaccine to be effective. But this is very patient dependent and very treatment dependent. And sometimes it is a very delicate balance between the clear and present danger of the malignancy versus a real but a less obvious risk of the infection. A patient who is on maintenance therapy, it's easy enough to chop and change. But a patient who is on induction therapy for a potentially life-threatening and a potentially curable disease, to chop and change treatment or stop treatment or delay treatment for a few weeks or several weeks in order to be able to administer a vaccine might not necessarily be the best strategy. In such cases, so myeloma induction therapy, our advice is if they are eligible to get the vaccine, go ahead and get the vaccine and time it in a way that is as far away from the next treatment as possible. And we will study the antibody levels to see whether they responded or not.
My philosophy with blood cancers patients and a COVID vaccine has been almost exactly the same that Dr. Stiff and Dr. Mehta just said. I have been encouraging all my patients with blood cancer, whether they are on treatment or not, to receive the vaccine, because as again Dr. Mehta said, it's a possibility that the efficacy may not be as good as somebody who is not getting chemotherapy or somebody who has no cancer. But certainly there is at this time no indication to say that the side effects are more compared to patients who don't have cancer or who are not on chemotherapy. So as Dr. Fauci said yesterday in one of the meetings, I was listening to him, any protection is better than no protection. So that's why I advise them. Same thing.
I guess I would tend to agree. You have two major cells that help mediate immunity. Your B cells, which produce the antibodies that we all talk about, and your T cells, the T cell cellular immune system. And the T cells are probably more important in killing viruses. So the fact that you might not have an antibody response doesn't necessarily mean that you're not going to get a T cell response. The problem, of course, is that we have no easy or good way of measuring T cell responses, unless Dr. Katz has some thoughts on this. So I tend to agree, get the vaccine. If there's a way of holding therapy or getting the vaccine for a period of time before you start therapy, for example, a patient with CLL or indolent lymphoma, get the vaccine and then start therapy, or wait till after transplant for a minimum of 6 months for an auto transplant, or 1 year, which is the traditional time we give other vaccines for an allogeneic transplant, it would be advisable. But again, we hope all for our blood cancer patients that we will have herd immunity. So it's more important potentially for all of us that your loved ones, your family, your friends get the vaccine, so that we can stop the virus, and your chances of picking it up, even if you're immune compromised and had the vaccine which failed, you'll be protected. Dr. Katz, any comment?
No, I would just second everything that's been said.
Okay, so hopefully that answered all of these. Next question has to do with mantle cell. And one person asked about maintenance therapy for mantle cell after transplant. And I'll throw in, should everybody get a transplant who has mantle cell? Which should, which shouldn't? And I'll throw that open to Dr. Vino and Dr. Mehta both.
Okay, so maintenance with the rituximab monoclonal antibody after chemoimmunotherapy for mantle cell lymphoma or after autologous transplant is considered appropriate because there is data to support that patients who are on maintenance therapy may have the disease in remission for longer time compared to patients who are not. But there is nothing indicating that the survival may be different. So that's the reason why it is not something mandated, but certainly, it is I do offer my patients who complete chemoimmunotherapy or transplant an option for maintenance rituximab.
I agree with what Dr. Vino Gopal has said. As far as survival impact is concerned, the new treatments have improved the survival of these patients so much that I think they're going to require much longer follow-up to see if there is an impact or not. Certainly with relatively limited follow-up, there doesn't seem to be an impact, but one would hope, as in certain other maintenance situations like myeloma, that with the passage of time, one will see an impact even on survival. As far as stem cell transplantation is concerned, I'm not aware of refined prognostic criteria that allow you to select patients that are more likely to benefit from transplantation than not. And I'm going to let Dr. Vino Gopal address that as well. But our philosophy has been that if the patient is in a situation that is physically good enough to withstand stem cell transplantation, and they've had an excellent response, preferably a complete remission, it is certainly worth considering an autologous stem cell transplant.
So this is a point where I mentioned that there is a national trial on ECOG is doing a trial for patients with mantle cell lymphoma in first remission. They do a clonoSEQ assay that Dr. Mehta mentioned being done for multiple myeloma, and if after initial therapy the clonoSEQ is negative, patients are randomized between transplant and ongoing maintenance therapy. So I think this is a question that is uppermost in many of our minds, and participating in this national trial, I think over time will allow us to answer the question of who should get a transplant. And again, this is based on minimal residual disease. Next, I want to move to some of the more exciting new therapies, and we're going to talk about BiTEs. Bispecific antibodies, and let's have Dr. Katz tell us what the heck a BiTE is, and then talk about some of the new uses for BiTEs and whether this will revolutionize treatment for blood disorders, and if so, which ones are likely to happen, and I'll have the others answer that as well. So Dr. Katz?
Yeah, so BiTEs are kind of a similar concept in some respects to what we had discussed with CAR T. With the CAR T, we reprogrammed the T cell in order to attack the cancer. In a BiTE, you're using also something that recognizes the cancer, but on the other side of it, you're using something that recognizes the T cell. So that's able, therefore, to bring the T cell, which can kill, to the site of where the cancer cell is, and then can kill it. And people have also been playing with various types of BiTEs, ones not only that get T cells there, but other killing cells like NK cells, or even three-way things, trikes. So that's the general description of them.
Okay, Dr. Vino Gopal, BiTEs for lymphoid diseases. I know there's some new CD20 BiTEs that are being tested. Can you talk about those?
Yeah, I think Dr. Stiff has mentioned before the drug called blinatumomab, which probably was the first BiTE that was approved by the FDA, but it is approved for specifically acute lymphoblastic leukemia. But we and others have done clinical trials in lymphoma with blinatumomab, and it's quite impressive. And as Dr. Katz said, not only the mechanism, but also some of the side effects we see with these drugs like blinatumomab and BiTEs are similar to that of CAR T in terms of so-called cytokine release syndrome or CNS or neurologic syndrome. They are similar. So, I mean, there are several BiTEs being explored in lymphoma. In fact, in the last American Society of Hematology meeting, at least 3 of them, many of them exciting, and with very good responses in patients who had disease come back after chemotherapy and some of the other immunotherapy, including stem cell transplant. So BiTE certainly has a role in patients with lymphoma in the future.
And myeloma. And you are muted.
Sorry. In myeloma as well, BiTE compounds, antibodies are being explored with results that are interesting. One of the weaknesses of BiTE therapy is that a lot of the treatments in lymphoid malignancies do tend to suppress the immune system severely, and you have to have a reasonably intact T-cell mediated immunity, a good number of T cells for BiTE therapy to be effective. That is one area where CAR T cells may have an advantage over BiTE therapy, because one is actually infusing the CAR T cells. But then, of course, in order to make CAR T cells, you've got to have T cells within the patient. So both of them do rely upon the patient's own immune system. And if that is not intact, then some of these treatments are not going to work as well as they should.
I'll mention bites for leukemia. Dr. Vino Gopal mentioned blinatumomab, and blinatumomab is been a very useful agent in the vast majority of patients who have MRD positive acute lymphoid leukemia. About 70 to 80% of those patients will be made MRD negative when used in this way. I have found, for example, that blinatumomab works best in patients with minimal residual disease and may improve ultimately outcome for transplant. And in fact, some people with blinatumomab who don't get transplant, and that's not usually how we use it as a prelude to transplant, are actually benefiting from this therapy necessarily without transplant if they're not transplant candidates. There are some bites that are being developed for acute myeloid leukemia. We're actually doing a clinical trial on CD123, which is a common antigen for acute myeloid leukemia. It's been effective. The first two patients, you always have initial success when the new treatment comes out. The first two patients that I had who had failed other therapies went into complete remission with this therapy. So I think this is an area that you're going to see and hear a lot more about. There are side effects, as we've heard about. Patients do need to go into the hospital frequently to start these therapies, and they can end up with significant toxicities, including blood pressure drops and infection risks associated with them, just like they can with CAR T cells. There's a lot of questions on transplant, and as a transplanter, I feel like we should answer some of these questions. Some of them have to do with chronic graft versus host disease. This is a condition in survivors that are doing well long term who have disabilities that can be either mild or severe, and acute graft versus host disease, which occurs in the first 100 days after transplant. And it was only within the last few months that the FDA finally approved the first drug ever for the treatment of acute graft versus host disease. That's ruxolitinib, or the brand name is Jakafi, which does seem to ameliorate acute graft versus host disease. And there's some new treatments coming down the line that are monoclonal antibody based as well that we're going to be testing nationally through the BMT-CTN clinical trials network. For chronic graft versus host disease, that drug also produces some good effects, and there's a cousin drug to that also is being developed that looks promising, and is being tested in ongoing clinical trials. But for most patients with chronic graft versus host disease, it's a disease that we are doing a little bit better at controlling side effects, symptoms, and you need to maintain very close follow-ups with your transplant team because side effects of chronic graft versus host disease and the treatments can predispose you to increased risk of infections. One of the questions, and I'll ask Dr. Mehta, was, is there an upper age limit for transplant? There's actually somebody who said, why is there an age cutoff of 77 for transplant? Mostly if you came through the first transplant successfully at the age of 75.
So for autologous transplantation, Medicare had imposed an age limit of 77 for in myeloma, but that has now been removed. So in practical terms, I think the age limit is really dependent on how the patient's general condition is. We have transplanted autologous transplants in patients over the age of 80. 81 is our oldest, with excellent tolerance, and the gentleman who is alive 4 years later in remission and doing well. Dr. Vino Gopal and I have patients in common with lymphoma who are in their mid-70s at the time of the stem cell transplant. The allogenic stem cell transplant, that's a donor stem cell transplant, is a different matter altogether, and that tends to exact a much greater toll on the body. In general, I think it's very difficult to do a transplant over the age of 70 from a donor. It's not impossible, but for patients who are 70, 71, 72, one has to be exceptionally careful and exceptionally selective because even though the mortality might not be very high, it is still high. the morbidity and the side effects of the procedure could be prohibitive. And in chasing the very attractive prospect of cure, one could go from the frying pan into the fire of chronic graft versus host disease and a whole bunch of other complications that could compromise quality of life very significantly.
Okay, so now it's time for the chat questions, and these are going to get really specific. So bear with us, and I'll throw it open to whoever wants to answer these. Can you explain to me this FISH panel? Positive for IgH, BCL2 fusion, 81%. Positive for 3 or 4 copies of 2Q27, 25%. Positive for 3 copies of 8, 16%. And positive for translocation 1418. I would presume that that's in lymphoma. Dr. Vino Gopal, want to try?
I'm also happy to talk a little bit from
please.
Standpoint on this. So there's 2 things that you have. First is mentioned the FISH panel, and then there was the translocation, that's what the T stands for, between chromosomes 14 and 18. That's coming from a cytogenetic analysis. The chromosome 18 is actually where the BCL2 gene is, and chromosome 14 is where the immunoglobulin heavy chain enhancer is, which drives the expression of BCL2. So the T1418 that you see from the cytogenetics is the same thing that you're seeing under the FISH for the IgH BCL2 fusion. The 81% afterwards refers to the percentage of cells in which they see that particular finding. The other things that they see is 25% of the cells have a duplication, or more than a duplication, a triplication in some cells and quadruple in some cells of a region of a chromosome that is chromosome 2q, and only 16% of the cells have 3 copies, a triplication of chromosome 8, using the particular probe that they were looking for on that chromosome. So that's in general what your FISH panel is saying.
And why is that important?
So I'll answer for the IgH BCL2, which we know the most about. And again, something that my lab studies and which the Leukemia Research Foundation funded. BCL2 is actually an anti-apoptotic protein. It helps the cells live. And in the case of cancer, we don't want them to live. So this is one of the mechanisms by which this type of cancer, in particular here, it looks like it's either a follicular lymphoma or a diffuse large B-cell lymphoma, was how it arose. And there are targeted therapies now that goes against these, particularly a drug called venetoclax, which has been pretty remarkable, I think, which is a small molecule that inhibits this BCL2 protein. But perhaps I'll let Dr. Vino Gopal take it from there.
I don't think I have anything to contribute to what you said, Dr. Katz. You completely answered the question, and exactly as you said, we even have a therapeutic target so that there is a drug that is FDA approved, venetoclax, which Dr. Katz just mentioned.
Okay, next, LOXO 305 clinical trial. Does it look promising for relapse CLL? And more importantly, do you recommend genetic retesting before you start treatment, a second or a third treatment on a relapse patient?
Yeah, I can answer the second part first. That is, in CLL and many other diseases where we know the pattern of relapse, that means a patient responds and then come back with disease later on, then you come up with another treatment. In these diseases, whenever possible, when the disease comes back, you should do some studies. If it is a lymphoma, you should check a biopsy to make sure it's the same type of lymphoma. And if it is CLL, it's always a good idea to check the molecular factors to see if there is a new molecular mutation that came up, which might open up an opportunity for a new drug that is targeting that particular mutation. So the answer to the second part is clear. Try to do the study whenever the disease comes back, if possible. The first part of the question, LOXO 305 is one of the exciting drugs in CLL. As you know, in CLL, the so-called BTK inhibitors or Bruton tyrosine kinase inhibitors have changed the way we treat this disease. Examples are Imbruvica, which is the commonest, or ibrutinib, then acalabrutinib and zanubrutinib. These three drugs are on the market. They are all BTK inhibitors. The point I'm trying to say is, once the BTK inhibitors do not work, and once the BCL2 inhibitors we just talked about, the venetoclax doesn't work, then in CLL we are kind of stuck. And LOXO 305 is one drug which can work in patients who have mutations in BTK, and therefore BTK inhibitors don't work. So the point is, this LOXO 305 and similar drugs are going to be the future in CLL once the patient comes back with disease after treatment with BTK inhibitors.
Okay, next, my brother was diagnosed with CMML and is exhausted all the time. He asked the doctor about it and nothing is done. When he asks about treatment, the doc says not yet. Your thoughts? Maybe I can take a stab at this. CMML is chronic myelomonocytic leukemia. Maybe Dr. Katz can talk a little bit about it. This is a disease with a varied prognosis, and some of the genetic testing that we talked about when we first started are very important in describing prognosis. In fact, there's a new classification that talks about certain prognostic factors with CMML, and it has to do with the elevation of white count, whether or not there's any blasts, which are abnormal cells in the peripheral blood, how low the hemoglobin is, and again, certain genetic factors. And all these will wrap up into a diagnosis. If somebody has a very good prognosis, then we might hold off on therapy. If you're otherwise young and have an adverse prognosis, we might go all the way to doing an allogeneic or donor transplant shortly after you're diagnosed. So patients with high-risk CMML or CMML2 may need a transplant, especially if they're under age 60. So why is he exhausted all the time? Again, this could be because the patient has a moderate anemia. It could be that he has a mild to moderate anemia and has chronic lung disease, and 1 + 1 is 3 or 4 as far as symptoms. It could be also that his spleen is enlarged. It's sagging in his abdomen, and you can get a large spleen in CMML and can cause symptoms regarding this as well. And finally, and we should never discount the diagnosis and how that affects patients' psychological status. If I have a diagnosis of chronic leukemia and the doctor says I can't do anything about it, or the treatment's worse than the disease, that might affect how I feel in general. And again, if you're not getting what you need from your doctor, push them. And if you're still not getting what you need, consider a second opinion. That's just something that I think all of us would talk about and recommend for you. The next is a diagnosed with splenic marginal zone lymphoma. Patient is getting rituximab, obviously single agent. What is the future prognosis and treatment, including Rituxan, and what chemo? What's the worst case scenario?
Splenic marginal zone lymphoma is a type of low-grade non-Hodgkin's lymphoma where most of the cancer cells are located in a big spleen, enlarged spleen. There may be some disease outside in a lymph node or bone marrow, but mostly the cancer cells are in the spleen. And most patients will come with low blood counts because the marrow is functioning, but the spleen is basically destroying them. So one of the very effective treatment in splenic marginal zone lymphoma is to remove the spleen. In fact, I have patients who had spleen removed, and more than 10 years, they have never seen the disease back. And coming back to the second question, rituximab as a single agent, yeah, it's a good treatment if you are not able to get the spleen out for whatever reason. It is a good treatment, but it is not something long-lasting. Therefore, you could combine with a chemotherapy drug. And more recently, there are drugs approved for marginal zone lymphoma, including the drug ibrutinib, would be a consideration for relapsed marginal zone lymphoma.
Okay, are any of the docs aware of trials or FDA-approved inhibitors for RUNX1 mutation? Dr. Katz, you're on the hot seat here. What is RUNX mutation? When do you see it? Where do you see it? Why is it important that we are even talking about it?
Yeah, sure. So RUNX1 is a transcription factor that drives leukemia, particularly acute myeloid leukemia, and comes with certain prognosis along with it. And so, since it's driving the leukemia in many different cases, and some by mutation and some by translocation, it could be a good target as well.
And guys, are there any targets? I don't think there's any, certainly there's no FDA approved treatments. Are you aware of anything coming up on this?
Yeah, I've seen a few papers, but all in the preclinical setting where people are trying to target those mutations, using various mouse model type approaches.
Okay. Next question. There was a BCR question and a PCR for BCR able. And again, unless you're 0.000, you should not stop your therapy. And 0.01 is positive. There's actually a clinical trial going on nationally of adding a second drug to patients who have minimal disease like this in hopes that we can convert people to 0.000. But again, unless it's 0.000 and you stop the drug, it will come back. CML is a disease of the pluripotent stem cell, which means that's the cell that produces all the other bone marrow cells. And unless that cell is knocked out, which doesn't happen very often in this disease, the disease will come back. So yeah, you can take a break, but it will come back. And in general, my feeling is that you don't let the cat out of the bag and try to get it back in the bag. Maybe Jayesh, Dr. Mehta, do you have any additional thoughts on that?
No, I think continuation of therapy is very definitely important. In the particular question that was asked, where there is pericardial effusion, perhaps a change in the treatment strategy could be considered, but stopping the treatment completely, unless it's zero, is not safe. And as we discussed, there are clinical trials where the molecular test has become completely negative. Withdrawal of therapy has certainly been considered.
Okay. Next one is, how is the management for blood cancers for poor people in third world countries? My friend in the Philippines has been diagnosed with a blood infection and told his busulfix chemotherapy pill will stop him from getting leukemia. I presume acute leukemia, and he has chronic myeloid leukemia by 3 different doctors. She's responding pretty well to the busulfix, but the whole situation is extremely shocking to me. Jayesh, you want to comment on that?
Yeah, it's a tough one. I mean, treatment of malignant diseases is very expensive in the Western world. It's equally expensive in third world countries on a relative basis. And unlike a lot of the Western countries, where even in the US there are deficiencies, but by and large, most patients have some coverage. In a lot of the developing countries, there is no third-party coverage, and individuals have to come up with funds to pay for their treatment on their own, which makes it completely devastating. Clearly, it seems like this gentleman is getting busulfan for chronic myeloid leukemia orally. And the last time I saw that being used was in medical school, and then came hydroxyurea and then interferon and now all other agents. So I guess there are heartbreaking scenarios elsewhere, but in each system one has to operate within the constraints that are placed by the system.
I'll just quickly add that in addition to treatments being limited, diagnoses can also be limited in the third world setting. They don't often have access to some of the more advanced molecular tests that we're talking about, or high-powered flow cytometry machines, or even simple immunostains that are necessary to help tell us between whether it's a B cell or a T cell lymphoma, as we've been discussing.
Okay. I have, so there's a question on, a couple questions on hairy cell leukemia, which is another chronic disease. What about bites for hairy cell leukemia? Or what's the newest treatment recommendation for hairy cell leukemia? Dr. Vino Gopal?
Briefly, hairy cell leukemia, the historical standard of care is a drug called clofarabine, which has been around for decades, and we still use that as the first line. And if the disease comes back, which usually happens after several years because the initial remission is very long, if the disease comes back, you can try the same drug or some of the new drugs, including targeted drug. There is an FDA-approved monoclonal antibody called moxetumomab, which is very effective. And in patients who come back with disease after that, you could use the drug called vemurafenib, which is an inhibitor of a molecular marker called BRAF, which is present in most of the classical type of hairy cell leukemia.
Okay, I have diffuse large B-cell lymphoma that's transformed from follicular last year. I was just treated with an investigational drug and lenalidomide and have achieved remission. What do you think the next step should be for treatment? An auto or an allo stem cell transplant, CAR T cells, or something else? I was initially diagnosed with NHL follicular 13 years ago and received R-CHOP chemo, was in remission for 6 years. Thereafter, received Rituxan maintenance and watch and wait for 2.5 years.
I mean, it looks like you had low-grade lymphoma that transformed to aggressive lymphoma, and the disease has come back even after an investigational treatment combined with lenalidomide. I'm assuming that was a monoclonal antibody like tafasitamab or so in the clinical trial. So I think the point I'm trying to say is if you are in good health, you should try to proceed with a cellular therapy option, which is either an autologous stem cell transplant or CAR T.
Dr. Mehta?
I think as far as hairy cell leukemia is concerned, I don't think I have anything else to add. Allogenic stem cell transplantation is appropriate, but I think very few people actually end up proceeding that way because of the effectiveness of the treatments that are available and the age of the patient.
Okay, I would agree. I think a patient like this, if they're back in remission, should get an auto transplant, but could also get CAR T. But it's important to say that if you're in remission, you're not a CAR T patient. You have to have active disease or the CAR T cells won't magnify in vivo into your body and kill the cells. So it's really not effective for somebody that's in a minimal residual disease state. It's not a finishing off therapy. It's a hammer, if you will, or a sledgehammer. An autologous stem cell transplant would be and has long been considered the standard of care for somebody with a transformed follicular lymphoma to large cell lymphoma who's back in remission. One last question is a question that we all always get, and it's sometimes hard to answer. So we're going to finish with a hard one, not an easy one. My father and one of his brothers both died of leukemia. How worried should I be about this being genetic, especially in regard to my children? I'll start with Dr. Cass. This will be your last comments, and then we'll end.
Thank you. It's been a pleasure to discuss this with everybody. Yeah, I agree. Difficult question. As we started earlier, there are genetic components to just about all diseases, but it's not a straight Mendelian disorder where if you have it, then your child will have it. And so I wouldn't overly rush to be necessarily worried about it. There's a lot of environmental factors that take a place that cooperate with genetics. And so it's something to watch, but I wouldn't let it dominate, I guess, your outlook.
Dr. Vino Gopal.
Yeah, I don't think I have anything to add to Dr. Katz's statement that certainly, the possibility of leukemia being inherited is very, very rare. And therefore, I wouldn't consider that as a fact.
And Dr. Mehta.
So I think in this particular instance, and in fact for all hematologic malignancies, the epidemiologic data are very clear that while there is no inheritance, the risk of the first degree relative of a patient with a hematologic malignancy developing a hematologic malignancy is higher than age-matched and otherwise matched controls. If you've got two people in the family, perhaps that risk is even a little higher. But since the baseline risk itself is small, even if the risk is doubled or tripled, the risk is very small. So I think it is very important not to worry too much about this. And a question that often comes up in patients with myeloma, where one can do a blood test and show that there is a small abnormal protein present, which otherwise may not have been detected for many years, is if you discover that there is such an abnormality, which is of no clinical significance at the moment, what effect is it going to have on your life? Are you prepared for the burden of the knowledge that there is a small seedling somewhere in the body which might or might not cause the problems? I, for one, myself, would not want to know such a thing.
And I'll just add that I agree with the others. There are certainly small populations of patients who may have what we call a germline mutation. In other words, genetics that they're born with, that as they age, these germline mutations are more a step in the multi-step pattern of getting acute leukemia, for example, so that you have a germline mutation and a second hit and gives you the leukemia. And again, so there is certainly some genetics associated with this disease. And in fact, for those with germline mutations who are considering an allogeneic transplant, there's a call over the last several years to perhaps we should be testing the donors, especially if they're sibling donors, for the same germline mutation, because those may ultimately end up with the same type of disease. So definitely something that you should ask your physician about. And with that, we'll end. I'll turn it back to Carrie. It's been a delight to spend the last hour and a half with you all. I'm sure that the other pro bowlers here today will agree. And these are very good questions. And hopefully we can meet again next year in person and answer your questions potentially a little bit more completely on an individual basis. So thank you all for your attention.
Yes, thank you so much. And to all four of our panelists today, thank you so much for giving of your Sunday and for the very informative program. We all appreciate it. So thank you again. And one last plug for our Managing Side Effects program coming up on February 22nd. You can register on our website, allbloodcancers.org. Thank you again and have a wonderful rest of your day.